Hello, and welcome to the Love Mia Vita podcast. I'm Gerianne DiPiano, CEO of FemPharma. Thank you for joining me as we discuss all things women's health and wellness. Please note that this information is simply that. It's information to help you to think through your decisions. Please consult your medical practitioner to discuss your personal situation. Thank you. Hi, Katherine. We're back again with the
Hello,
Love Mia
Jerry.
Vita podcast. So today, my co-host and guest is Dr. Katherine Sherif, and Katherine Sherif and I do this quite often. And if you haven't tuned in before, you absolutely should tune in to the Love Mia Vita podcast, where Dr. Sherif and I cover a number of different topics. And Katherine is a professor of medicine at Thomas Jefferson University. She's also a member of the FemPharma Medical Advisory Council. But Katherine, your background includes so much more, so perhaps you could share more about your background with our listeners.
Well, I'm a professor of medicine at Thomas Jefferson University and an advocate for women's health. And my interests range from reproductive issues in women to polycystic ovary syndrome to heart disease in women. So it covers a lot of territory.
So the broader way in which to explore women's health, as I've said in the past, does not consist of a set of ovaries, a uterus, and breasts. It's much broader than that. We have to take into consideration the whole woman, and that's actually what Dr. Sherif is all about. She looks after the whole woman, not just specific body parts. So with that, what we're covering today is actually the part 2 of a podcast that we've done on cardiovascular disease. The part 1 of this podcast is available wherever you get your podcasts. And the focus on that particular podcast is really cardiovascular disease in midlife, the risk factors, what you can do to change some of your risk factors, and how you may want to consider moving forward with your healthcare practitioner so that you can properly identify those risk factors and then take action. So that was part 1. In part 2, we are going to examine cardiovascular risk in a younger age group cohort, and specifically women under the age of 55, which shockingly, so you might be surprised to know that cardiovascular disease in a younger age group cohort of women is on the rise, and that is both striking and horrible at the same time. We need to take action. You need to take action if you're a woman and you are not familiar with some of these risk factors. We want to enlighten you today. So, Katherine, let's talk about cardiovascular disease in a younger age group cohort in women, and the startling statistic that we now know, which is the rise in that age group cohort, bringing women to about the same risk factor that men have. So in men, it's actually declining or stagnant. In women, it's actually on the rise.
Yes.
Some of these factors, what are they?
Yes. So there are multiple risk factors in women that we consider non-traditional, because really the traditional factors, risk factors for heart disease were based on men. And they are risk factors for women, but they also differ in women. And, just to back up for a moment, Jerry, at our last podcast, we talked about how cardiovascular disease is the leading cause of women worldwide. And it's been going down gradually in all groups except young women and women with diabetes. And in spite of the fact that it is the most common cause of death in women, there's a belief that women have a lower risk of cardiovascular disease when they don't. And so as of 2024, women are undiagnosed, untreated, and underrepresented in clinical trials. And so we don't have the data that we need to prevent heart disease in women. We don't have the management tools. And risk calculators, that's something we use in the office. We plug in your LDL or your weight, your age, your blood pressure, and so on. And it tells us this person in front of you has X risk for heart disease. But in fact, it doesn't count the things that we're going to talk about. It doesn't talk about preeclampsia in women, hypertension in women. Any woman who has hypertension during pregnancy is much more likely to have heart disease later on. So these risk calculators were really based on data in men. So they constantly underestimate heart disease in women. Some of the other risk factors for heart disease in young women, besides polycystic ovary syndrome or just having irregular periods, even if you don't have that diagnosis, they include stress. And stress meaning everything in the environment, whether it's work stress, personal stress, the fact that you have 3 jobs, the fact that you're a caretaker, or you have 2 jobs, one is during the day and one is when you go home to take care of your children. And women are under enormous stress. So those are some of the risk factors in women that are sex specific.
So it's interesting, as I was looking at some of the research, one of the, you talked about what I'll call 2 broader categories, one being mental health and specifically anxiety and depression. And there has been a substantial amount of investigation into the ways in which stress, specifically anxiety and depression, impacts women. And you might imagine that if you have anxiety and you have stress, and by the way, they have a similar pathway from a neurological perspective. But what we know is if you have stress, that does have an impact on cardiometabolic health. And maybe we could talk about that first. And then the second broad category are some of the reproductive health issues. And these are very specific and unique to women. And they start with women who are in menarche. So when we talk about how this affects women from menarche to menopause, as we said, we've talked about menopause, but women who are still menstruating and capable of bearing children, or maybe they're not capable of bearing children because of certain diseases or disorders, they are still at risk in their younger age group cohort. We could cover some of these and some of the solutions that we might suggest that could be discussed with your healthcare practitioner.
So you mentioned anxiety and depression. People in a culture who have less power have more stress, and stress is manifested in your body. You have increased inflammation. You can see that inflammatory markers are higher. When you have increased inflammation, the immune system affects the body in negative ways and contributes to atherosclerosis. You have to have a certain number of conditions to build up atherosclerosis in the arteries. And if you feel peaceful, and if you're at a job that feels fulfilling, and you're not frustrated every day, your stress levels are lower, your inflammation is lower. That's why people meditate and do things like yoga and exercise to decrease, for more peace and less inflammation in their bodies. So the people with the least power in a culture have the highest rates of inflammation and go on to have more coronary vascular disease.
So I know that there have been some objective assessments that were done looking at the brain and looking at how the brain is activated in a population of women who are subjected to stress. And what we see is that you see a lot of the same type of metabolic activity in a stress-related brain when you look at this very objectively. So this isn't hypothetical. I mean, we might say, well, yeah, I'm stressed out. My blood pressure increases. You're right. Inflammation, when you're stressed out, when you have anxiety, you have the inflammatory factors that come into play, but actually your brain starts to change. And those same, that can also impact your overall cardiometabolic health. So the question is why is there heightened increase in this activity in young women? I think you described some of it. Women have historically been the caregivers. They have historically had multiple responsibilities, and they never get a break. So when we talk about self-care, what are some of the ways in which we can address if you have mental health challenges, and specifically anxiety and depression, what can be done to help to ameliorate that?
Yes, anxiety and depression are undertreated. Um, People often have poor coverage for mental health providers. They or they're given a list of psychiatrists and psychologists by their insurance company, but those people are no longer taking patients, or they are retired. They're full, and good people tend to fill very quickly. And it requires, when you feel your worst with anxiety and depression, it requires you to make phone calls. There are so many obstacles to getting cognitive behavioral therapy, and obstacles to getting an antidepressant.
The other part of this that women need to understand, and this is a fact, many of the antidepressants were not studied adequately in women, in individuals with female sex organs. And that is a problem because we really don't have a lot of good data that demonstrates that these antidepressants work equally well during your menstrual cycle, before your menstrual cycle, and when you're in perimenopause or menopause.
Yeah.
So this makes it a bit of a challenge. So what we tend to do is we sort of mix and match the antidepressant with the kinds of symptoms that you're experiencing, but that still does not speak to some of the metabolic symptoms and issues that you may be facing when you start antidepressant therapy. So it is also important that you understand what your other risk factors are. And I think we should talk about those other risk factors because, for example, let's say you are pre-diabetic, and let's say you were able to visit a psychiatrist and your psychiatrist says, I'm going to prescribe this particular antidepressant, but we know that antidepressant will increase your weight, right?
Yes.
So you're going to experience weight gain. Perhaps there is a different antidepressant that he or she could prescribe that would reduce the potential for weight gain. It's not to say that you don't want to consider using an antidepressant, but you want to consider one that works with the rest of your cardiometabolic health so that it doesn't impact it in a material way and actually exacerbate some of those symptoms.
Exactly. Exactly. And we know so little about how the antidepressants work and in whom they work in, that we often just try experimenting. Try this, let's see how you feel. If you don't feel better, we'll try another one. Oh, you had side effects on that one, you gained weight. Okay, let's switch it out for another one. It's very difficult for us to predict who will do well on which antidepressants and who will and who won't get side effects. And one of the most pernicious side effects of antidepressants is gaining weight, because that makes women feel terrible.
So there's that. And then when we also think about mental health and the impact of anxiety and depression, we know that that also impacts sleep.
Yes.
If you don't sleep well, you tend to gain weight because you tend to eat improperly or eat more frequently to provide that energy that sustains you. So it becomes a bit of a vicious cycle. We
Yes.
are seeing an increase in rates of depression among young people. There's no secret. I mean, we have a mental health crisis. You said this earlier on in this conversation. We have few providers and many thousands, if not hundreds of thousands, of individuals who need this type of therapy. So there is a bit of a mismatch. And it started before the pandemic, and it was exacerbated by the pandemic. So it's important to take care of our mental health, seeing a professional that can adequately diagnose it as either anxiety or depression or possibly something else. keeping in mind what your risk factors are, knowing your risk factors, and then trying to find a way in which to address that. So I think that, I think we've covered the mental health component of this. Then you mentioned reproductive health, and I'd like to have you delve into that a little bit more so, because women probably don't appreciate that their reproductive health and some of the conditions that you mentioned actually predispose them to an increase in cardiovascular disease and risk.
Yeah, so it goes back to the silos we have in medicine where reproduction is reproduction. And so when you're pregnant, for those 9 months, you're immersed in these pregnancy hormones, and nobody thinks about heart disease. But what we know is that if your blood pressure goes up during pregnancy, or if you develop diabetes, gestational diabetes during pregnancy, your risk of cardiovascular disease is substantially higher than someone else who was pregnant and didn't have pregnancy-induced hypertension or pregnancy-induced diabetes. So they really, this is not just a reproductive state, but it's a reproductive metabolic state. And it also has effects on your children and whether your newborn ends up in an intensive care unit. So one of the things that these risk calculators don't do, what they don't take into account is that if a woman has gestational diabetes, that significantly increases her risk for heart disease. But we don't put that into the calculator. We just say the usual. Does she have high cholesterol? Does she have high blood pressure? How old is she? Is she a smoker, right? But nothing about the reproductive area. It is completely ignored.
Yes. And it's interesting that you talk about some of the pregnancy related issues, such as gestational diabetes. We also know that for women who have infertility issues caused by conditions like polycystic ovarian syndrome, and I know this is an area of expertise for you, among others. So let's talk a little bit about PCOS and how that may impact a woman's cardiovascular disease risk.
So in polycystic ovary syndrome, or PCOS, women have high inflammation. And even if they're not overweight, we know that when many women with PCOS are overweight, and we know that the more fat cells you have, or the bigger your fat cells, the more inflammation you have. And that's damaging to your body. And then if you have PCOS and you're overweight, you have even more inflammation. But even slender women with PCOS have inflammation. And they go on to get more fatty liver, which is a risk factor for heart disease. They get high triglycerides and low HDL, the good cholesterol, another risk factor. They get elevated blood pressures. They're more likely to have diabetes. So there's so many ways that this reproductive disorder makes you vulnerable to heart disease.
What about endometriosis? What do we know about endometriosis as a cardiovascular risk factor?
Well, we know that the risk is higher, and it may have something to do with inflammation, or at least inflammation is the common denominator. We know that women with PCOS, with endometriosis, have higher estrogen levels than women who don't have endometriosis, but in this case, it doesn't seem to be protective.
When we think about women who have endometriosis who are being treated for the condition, we know that there are a variety of different ways, not necessarily great ways in which women are treated for endometriosis. So we know that if it's mild endometriosis, they will use birth control pills. And we could talk about oral contraceptives in a minute. So birth control is often the first line of, I hate to say defense, but it is the first line of recommendation by the healthcare practitioner. Presumptively, it is used in what is assumed to be endometriosis. And we know it takes a long time for that diagnosis to be made, which is also unfortunate. Once it is laparoscopically diagnosed, because that is the definitive way in which endometriosis is diagnosed, it means they actually go in, just to put it in very plain language. They go in and they take a look. They scope you. They stick a little laparoscope in, and then they examine the tissues in your pelvic and reproductive organs to determine whether you have these lesions. Once it's determined, then they have options to put you in chemical menopause. Hate to say this, but it's like castration for a male. So you're placed in chemical menopause, and the very fact that they are now suppressing estrogen then takes away some of the protective effect. So with endometriosis, it shouldn't be surprising that because of the inflammation, because of some of the quote unquote treatment options,
Right.
there are treatment options, there isn't a lot that is being done to progress in that area. So if you are a woman with endometriosis, it's important to get it under control, but it also means that you need to look after your cardiovascular risk factors, because the potential is that you could be increasing at an increased risk rather. So that's endometriosis. What about infertility? Infertility treatments.
Yes. So infertility treatments require the use of drugs to stimulate ovulation. We don't know the long-term effects of those drugs. We do know that women get very high levels of estrogen to try to stimulate the formation of mature eggs. And again, that is associated with inflammation. So infertility, let's say you have infertility and you're not on fertility drugs, but you have infertility because you have premature ovarian failure. Well, then your estrogen is down, and estrogen is protective for us. And then in the right doses, then your inflammation goes up, and anyone with premature menopause has a higher risk for heart disease than women who have typical menopause around age 50.
So infertility, whether it's because of some other secondary characteristic, or it is a result of you're taking some treatment. So if we cover that topic, this is also an area where you want to be mindful of some of the increased risk. Either way, whether you're undergoing treatment to help you to conceive, or if it's as a result of another condition, such as the ones that we described. And then there is something that was surprising to me, which is pregnancy loss. So I presume for women who have had miscarriages, frequent
Yes.
miscarriage. Let's talk about that a bit.
Yeah, so the factors that predisposed you to miscarriage in the first place may be playing a role in your future development of cardiovascular disease. So is it inflammation? Is it clotting disorders that haven't been diagnosed, and the clotting disorder cut off the oxygen supply to the fetus, causing a miscarriage? Or is it a miscarriage because there's too much testosterone in your body, and too much testosterone in women predisposes them to cardiovascular disease, as in PCOS. So several different factors in miscarriages.
And then we talk about birth control and oral systemic birth control in particular, because we do know that that does increase the risk of certain types of conditions. And let's examine that. By the way, we just did a podcast recently on birth control and various birth control options. We want women to understand that we're not against birth control. But again, this is where knowing your body, knowing what diagnostic tests you should request that your physician undertake to better assess your risk factors could be very important. So let's talk a little bit about oral systemic birth control.
Yes, so birth control pills are not all the same, but we often treat them as if they're interchangeable. So almost all birth control pills contain an estrogen component and a progesterone-like component, which we call a progestin. And the amount of estrogen can vary, and the more estrogen that's in there, and this is an estrogen that somewhat resembles our own estrogen, but it's not identical. The higher the estrogen in that birth control pill, the more inflammation you may have, or it may affect your mood. And then as far as the progestin goes, some of them behave a little bit like testosterone and some of them do not. And so when women are asking for the birth control pill, they should check with their clinician about what are the components and do they have any adverse effects. Some birth control pills increase C-reactive protein, which is a marker of inflammation. Some of them cause microalbuminuria, which means you're spilling little bits of protein into the urine, which means there's a metabolic problem with those hormones. So another problem with the birth control pills, or another risk, is blood clots. So we don't routinely screen the population for blood clots. We wait till people have blood clots, and then we look for clotting factor disorders that they have in their blood. But what we don't do ahead of time is screen people for blood clots. If you have blood clots, you theoretically and actually people do get strokes. So there's another risk factor.
So we also look at the package insert on the birth control pills. Irrespective of the one you're using, you will often see what we refer to as in the industry as a black box warning. When you review that, it can be very, very frightening. So it is in there in that package insert because these are things that have been observed during the clinical trial process for any one of these oral contraceptives. The bottom line is what I think I'm hearing from you, Katherine, is you've got to know whether you have any of these risk factors that are present. I know we chatted about this in a previous podcast on birth control. We talked about smoking. We talked about weight gain. We talked about being pre-diabetic as potential contraindication to prescribing systemic birth control. What are your thoughts about that in terms of risk factors?
Smoking. Women who smoke have a greater risk of heart disease than men who smoke. And possibly it's the fact that the cigarette is the same dose of bad chemicals, but women's bodies are smaller, so they don't metabolize it the same way. And smoking increases inflammation. And some birth control pills increase inflammation, and you put them together and you get a deadly combination, much more stroke.
If you are, we also examine some of the risk factors around polycystic ovarian syndrome and the ways in which PCOS is often treated is also with birth control. And if that happens, then what?
Well, we don't know, but it's like this huge experiment. Give everybody the birth control pill and we'll find out later what happens. But if you already have metabolic problems, as you do with PCOS, and if your clinician says to you, well, the first line treatment is you go on the birth control before anything else, and they haven't looked at your liver function tests, they don't know what your blood pressures run, they don't know what your sugars are like, but they go ahead and put you on the birth control pill because it's the most expedient thing, and it takes much longer to talk about other types of treatments, well, then we are putting women at risk.
So now I'm gonna say something, and it's gonna appear very controversial. We believe in access, right? We believe in access to various options, birth control and other opportunities. We know that with the advent of telehealth it has emerged, it has grown, it is almost mature now. But with telehealth, you may or may not receive some of the insights about these risk factors. So I'm sitting across from you, Katherine, and I appear to be otherwise healthy. You can't see me from the waist down. So you don't know if I'm wearing a size 20 or if I'm wearing a 2. You also don't have any idea whether I smoke or I don't smoke. You don't have any insight into some of what we just discussed. So it's, I would presume it's your responsibility, person that's sitting on the other side of the screen from this healthcare practitioner, to fess up. If you're prescribed a birth control pill that has iron, now what?
Well, we don't know what your iron levels are. So iron is a pro-oxidant. And what if you're in one of those families with hemochromatosis and iron overload? You can't just hand out iron left and right.
So there's an example of an important risk factor that could be overlooked during this kind of a conversation.
Yes.
So while we want to encourage you as a young woman to take control, be in control, be prepared and not be scared. That was what we used during one of our podcasts, because it's important. It really is important. There's so many different options for you to consider that may also work to preserve your cardiometabolic health and specifically maintain those risk factors, or I should say, not maintain, reduce your risk factors. So all this is really important. And you're not fooling anybody but yourself if you're sitting across from the screen from a healthcare practitioner like a Dr. Sherif, and you don't disclose this, because Dr. Sherif might say, well, let me ask you about this. So if you don't know, you better find out. But you
Yes.
should have your own checklist. Know your family history, know what may be facing you. So now this sounds pretty doom and gloom. But
Does. Yeah.
let's revisit some of the opportunities, let's put it that way, and options that women may avail themselves of, because there are ways in which we can A, look after our cardiovascular health, and B, still receive the benefit of some of what we have in terms of therapy, whether it's cognitive behavioral therapy, whether it is pharmacology, or some other alternative way in which to improve our health.
Yes, so there are things under our control, even though it sounds like the world is out of control and we have so many, contaminants in the environment. Things that are under your control are your ability to move and to exercise. And people who exercise feel better mentally. And we know when you exercise, you also increase a hormone called brain-derived natriuretic factor, BDNF. And BDNF makes you smarter and builds more brain cells and probably builds more connections too, which is one of the issues in depression. So exercise and physical activity are under your control. Not everybody can afford to go to a gym or doesn't have the time to go to a gym, right? We need time and we need money in order to take good care of ourselves, but you can move. And moving itself, walking, keeping track of your steps are some of the steps that are some of the things that you can do to make yourself healthier. Even more important is your diet. You need to learn as much as you can about food and why the food you're eating, especially processed food, may not be the best food for you. But it takes a long time to get there. When you're tired, when you work too many hours, as I have, it's so easy to reach for something that's like a reward. So it takes a lot of work and discipline to eat well. Another factor which is under our control, and I don't want to leave this out, is loneliness. We know that people with social ties, even if they're weak social ties, where you say hi to this person, hi to that person, and you see them, they're not like these deep friendships. When you have more social ties, you do well, and your risk for cardiovascular disease is decreased.
And that is something that we hear a lot about with older individuals who tend to become isolated because of the death of a spouse, or maybe their children are out of the home, and so they're empty nesters, so they don't have a lot of close connections. But we often ignore that in a younger age group cohort. And there are lots of young people who are living alone, who've moved away from perhaps their parents or extended family members, and they may feel isolated and alone. And being alone is different than being lonely, as we know. But if you are feeling isolated and you are feeling lonely and disconnected, that also is a risk factor for cardiovascular disease. Then we tend to engage in maybe some harmful behaviors as well.
Yes. You know, we have a significant proportion of the workforce, younger people who are working from home in numbers we never had before because we're able to. And I worry about isolation for those people.
Yeah. So, all kidding aside, if you are lucky enough to have a pet, pets are actually a good way to help us to overcome loneliness too. So they tend to lower, when you have a pet, whether it's a cat or a dog or a ferret or whatever your pleasure, you tend to see lowered blood pressure because you're giving that pet affection. That pet will give you unconditional love. So having a pet actually does help. So think about having a pet. That can be your companion. And
Yeah.
so this is another option that you may want to explore if you have the ability to do so. And I know some younger folks may live in apartments or in other living environments where pets are not welcome, but if you do have the flexibility to bring a pet into your life, it's always a good option for you to, by the way, if you have if it's a dog, you could take the dog for a walk and then you get some exercise. And sometimes that's the best way to motivate yourself. Dog has to go outside. So
Yeah.
you have to walk the dog. It actually is a very good option to keep that blood pressure lowered and to improve your ability to get a little exercise in as well. Now you have an excuse. So we talked a little bit about the mental health aspects of this, the dietary aspects of this. Again, in a younger person, I'm thinking about how they may connect with other professionals, right? And so when you are across the screen from someone during a telehealth visit, while that may be expedient, this would be a recommendation. Find a healthcare practitioner, primary care practitioner who looks at your health more globally. Could be a great opportunity. If you're thinking about women and women's healthcare, you should also do a little bit of research to ascertain whether that individual understands women and women's bodies. So perhaps you choose a woman. If you're a female, you want to choose a woman. But it's finding someone that you can connect with face to face, where you can actually go in, take the time to make an appointment for an annual physical. Bring your list of questions. So this is something that I recommend all the time to my friends.
Mhm.
If you show up and you expect the healthcare practitioner to read your mind, and I've said this 1,000 times during the podcast, healthcare practitioners like Katherine are seeing 35 individuals per day. And although they care deeply, or they wouldn't be doing what they do every single day, their time is very limited. So the more efficient you can make your visit, the better your visit, the better your outcome. Bring your questions, do your research ahead of time. It's one of the reasons why we have the Love Me Avita podcast. We're giving you enough information to stimulate your further research into your health. That should inspire you to take the next step. Put your questions together, make an appointment. If you have a healthcare practitioner that doesn't quite jive with you, find another one. Sometimes it's a matter of investigating, visiting. It's kind of like speed dating, I suppose. And I haven't dated for a really long time, but you have to find someone with whom you can connect, someone that really gets you. And if they don't, you just move on.
Yeah.
So I strongly suggest that if you're a woman in your 20s, 30s, 40s, and you think that you are invulnerable, let's face it, we are not. We are not invulnerable. And you need to have the answers to these questions so that by the time you reach the age of menopause, you have addressed some of these underlying concerns. And maybe you don't. Maybe you're super healthy and you're going to live to be 106 and you're never going to have an issue. I pray that that's you listening to this podcast. That's my final tip. You think we covered
Wonderful.
it, Catherine?
I think we've covered it. Yeah, that's great.
Well, thank you once again. And stay tuned for the next Love Me Avita podcast. Part 1, if you haven't heard it, is available. And part 2 has just been completed. Thanks, everyone. And thank you, Catherine.
Thank you, Jerry.
Thank you for joining us on the Love Me Avita podcast. Love Me Avita means love my life, and that is a mantra we should all live by. Please like and subscribe wherever you get your podcasts, and check out our website at fempharma.com. Remember to live well and love me Avita.